So good evening, everyone. Thank you so much for taking time this evening to enjoy your dinner with us and to be introduced to the 2024 quality and risk coding information. This is our first quarter provider quality and performance training for 2024, and we'd like to make sure that you're aware of all of the new quality measures that are in place for the various payers, as well as the risk coding initiatives and the patient experience initiatives, which we'll be promoting this year. So with that, I wanted to first let people know that this activity is accredited by the Accreditation Council for Continuing Medical Education. It provides up to 1 hour of AMA Category 1 CME credits. Please, however, only claim as much time as you spend with us. So if you spend the full hour, feel free to claim 1 hour. If you only spend 30 minutes, claim 1/2 of an hour. And again, there are no commercial interests that would create a conflict of interest on any of these slides. On the next slide, again, I just want to make sure that people are again aware that this meets criteria for Massachusetts Board of Registration of Medicine for risk management study. And again, this will be 1 hour of risk management credit. And for Texas, this has been designated for 1 hour of credit for education and medical ethics or professional responsibility. In terms of our learning objectives tonight, we'll hopefully be again reviewing all of the new quality metrics for 2024. We'll be defining the impact of specificity in ICD-10 coding and the information that you need to be aware of. And we'll be talking about how Steward Healthcare Network performance liaison support practices to improve performance. On the next slide are a few housekeeping items. So number one, if your name appears incorrectly in Teams, please correct it with your full name and organization so we can send the email to you with your CME credit and with a follow-up survey. Secondly, please make sure your audio is muted. And if you do have a question during tonight's session, you don't need to wait till the very end, but feel free to click on the Q&A icon, which has a question mark at the top of your screen. It's about 4 over from the left, and feel free to enter your question into the Q&A icon. Towards the very end, we'll be reading these questions and answering them out loud. The meeting will be recorded, and again, you'll be getting a video of the actual meeting if for some reason you miss it. CME is again available as we discussed. If you have an IT issue or a specific feedback on the session, please reach out to Steward Healthcare Network or chicken.qualityteam@steward.org, and we'll be happy to try and address an IT issue in real time or help to answer any questions that you might have. On the next slide, I did want to make sure that people understand that in the past, we've traditionally incorporated mass health training during these sessions. We're breaking that out so that we just burden the Massachusetts providers with that moving forward. So online training for the new quality metrics for Mass Health will be Friday, January 26th at 8 a.m. and at noon. There'll be 2 sessions. And again, we'll look forward to covering, again, the quality metrics, risk adjustment best practices, as well as health equity data collection, which are important issues for Mass Health moving forward. On the next slide, I did want to just go through our agenda. We'll start by looking at our regional gap closure performance and how we performed as of September, which is where we've had data and claims downloads. We'll then talk about quality metrics, including chronic disease management, cancer screenings, immunizations and well care, and then other measures. We'll move on and talk about patient experience, and then we'll talk about risk adjustment. And finally, we'll end with performance liaison support, as well as questions and answers. And again, if you have questions about any topic, don't hesitate to click on the Q&A icon and enter those questions. Tonight, if you do have a question and I can't answer it, I'm joined by a group of incredible individuals who work with me, who often will have the answers to those questions if I don't know them. So I'm joined by Ginny Rigo, who's our Vice President of Quality, Joanne Zama, who's our Senior Director of Government Quality Programs, including Medicaid, Kim Moody, who's our Director of Process Improvement, Dina Post, who's our Manager of Risk Coding, Cassandra Richardson, who's our National Performance Manager, Kelsey Reed, who's our Manager of Patient Experience, and Alexa Park, who's our Member Engagement Advisor. And welcome to all of them, and thank you for all the work you put in getting the presentation ready. On the next slide, I do want to call out 2 specific areas of excellence that have recently come forward in the last couple of weeks. The first is the Harvard Pilgrim Healthcare Honor Roll. This is 53 physician groups that have been recognized as providing incredible quality performance by being recognized as providing top 25th percentile quality measures for NCQA across 15 HEDIS measures. These include asthma medication ratios, statin therapy for patients with diabetes, breast cancer screenings, among others. And congratulations to the primary care doctors in the Greater Fall River chapter, the Greater Haverhill and Methuen chapters, the Greater Neshoba chapters, the Greater Newburyport chapter, the Greater North Shore chapter, and the Central Mass chapter. And I do want to recognize that the Central Mass chapter received their honor roll designation with distinction. So congrats to these incredible doctors and for the work that they've done in terms of their 2022 HEDIS performance quality measures. Again, thank you so much for being members of the annual Harvard Pilgrim Healthcare Physician Group Honor Roll. On the next slide, I also want to call out 3 specific physician practices that have done a great job in controlling blood pressure. The Million Hearts campaign is a process whereby providers are able to document that over 80% of their adult hypertensive patients are adequately controlled in terms of their blood pressure. These practices undergo rigorous scrutiny to make sure that, in fact, that data supports that quality measure. And the Million Hearts campaign has recognized 24 different doctors or healthcare systems across the United States as being outstanding in terms of hypertension control. These hypertension control champions include 3 of our own doctors, including Dr. Rabin at the Stanton Internal Medicine Group in Brighton, Dr. James China in the Steward Medical Group in Austintown, Ohio, and the Indian River Primary Care Group in Vero Beach, Florida. So please join me in congratulating our Harvard Pilgrim Health Honor Roll champions, as well as our Million Hearts Hypertension Control champions. A phenomenal job on both parts in taking great care of our patients. Next slide. So let's start by working through our agenda in terms of regional performance. On the next slide, you'll see a summary of gap closure as of September 30th, 2023. If you take a look, you'll see that we had approximately 150,000 open quality gaps that were present before the year opened. And we basically have done a very good job of, as of September 23, controlling a lot of these different gaps. We still have opportunities in certain areas. Again, Ohio, Pennsylvania, and Florida are very close to target. And Arizona, Massachusetts, Texas, Louisiana, and Arkansas all have about a 10 to 15% variance to target in terms of closing quality gaps. So I wanted to just let people know that claims data continues to roll out through the last quarter of 2023, and we're hoping that all of our regions have done a great job of closing these gaps, and we are hoping that all regions can be in yellow with either very close to being complete or even green shading when regions are at target and doing better than they had been. So again, we do have an awful lot of quality gaps, and we're looking to make sure that we close as many of them as we possibly can to provide the highest quality healthcare to our patients. Now on the next slide, we'll start to work through quality gaps. And quality gaps can really be thought of as 4 large buckets of quality issues. The first is management of chronic diseases, and these include hypertension and diabetes. Our payers are looking for all of us to make sure that our diabetics have great blood sugar control and are having all of the appropriate care provided to them to prevent end-organ disease. And our payers are also looking to make sure that our hypertensives have their blood pressure controlled to prevent the progression of vascular disease. Now on the next slide, we'll start to talk about diabetes. This looks at diabetic control by region. And I will note that for Florida, control is a hemoglobin A1C of less than 8%. For Massachusetts, Ohio, Pennsylvania, and Arizona, diabetes control is a hemoglobin A1C of less than 9%. You'll see that in Florida and in Ohio and Pennsylvania, we are doing a better job than one would have expected in terms of performance to target. That's why those numbers are in green. And in Massachusetts and in Arizona, we have about a 10 to 15% variance from target. We're not quite where we need to be, and there is an opportunity to control this in a slightly better fashion. Again, this is through September of 2023, and we're hoping that as claims data rolls out for the last quarter, we'll see many of these red areas turn to green. Now, in terms of control of diabetics, the next slide will begin to kind of walk us through what is expected for diabetes care for patients moving forward. So in 2024, care of diabetics requires 5 different criteria. The first is a hemoglobin A1C of less than 8%. Again, these are adults with diagnosis of diabetes between ages 18 to 75. Doesn't matter whether they're type 1 or type 2. They all need a hemoglobin A1C, and that hemoglobin A1C should be ideally less than 8.0%. Secondly, all diabetics need control of their blood pressure. It's especially important to have blood pressure control in a diabetic because hypertension and diabetes together seems to, unfortunately, really promote the development of virulent atherosclerosis. So blood pressure for diabetics should be less than 139/89 moving forward. And we'll talk about more optimal control of blood pressure in just a minute. Third, all diabetics should have an annual diabetic eye exam. Now, if the eye exam was negative the year before, you can actually go every other year, but we're strongly recommending that all diabetic patients have an annual eye exam or a biannual eye exam if there's no evidence of retinopathy. Fourth, all diabetics need some evaluation of kidney function, including an estimated glomerular filtration rate with a BUN and creatinine, as well as a urine albumin to creatinine ratio. Again, this is looking for early diabetic kidney disease, and chronic kidney disease, unfortunately, is especially prevalent in diabetes, and it's the most common cause of end-stage renal disease requiring dialysis or kidney transplantation. So evaluating patients with diabetes for their kidney function early on is incredibly important, and getting them on a statin or an angiotensin receptor blocker to prevent the progression of chronic kidney disease is extremely important in diabetics and is considered one of the hallmarks of good diabetes care. Finally, in addition to checking a hemoglobin A1C, maintaining good blood pressure, an annual diabetic eye exam, and an annual kidney health evaluation, all diabetics ages 40 to 75 should be on a statin irrespective of their LDL cholesterol. And the reason, again, is that diabetics tend to have significant vascular disease associated with their disease. And many patients with diabetes end up with significant coronary artery disease or cerebrovascular disease. And statins are well known to prevent the progression of this in addition to or irrespective of their LDL cholesterol to start with. So again, this is preventive care for diabetes. Again, hemoglobin A1C, blood pressure control, annual or biannual diabetic eye exam if the patient did not have retinopathy the year before, an annual kidney health evaluation with an estimated GFR and a urine albumin to creatinine ratio, and statin therapy for all diabetics ages 40 to 75. Next slide. A couple of thoughts about hemoglobin A1Cs. Again, every patient should have a hemoglobin A1C at least once during the measurement year, and most people recommend at least twice during a measurement year. And again, the ideal hemoglobin A1C should be less than 8, and frankly, in many cases, should be less than 7.5. In terms of best practice, we recommend ordering the labs before the patient's appointment so you'll have it when they come into the office. Many people do a hemoglobin A1C with point of care testing, and that's perfectly appropriate, but one needs to document that in the medical record, including the date as well as the result. Third, please make sure that diabetic screening tests are ordered at least yearly or at least as often as one needs to ensure control. You can certainly build care gap alerts into your electronic health record, which will remind you of when you need to have that repeat blood test performed. Follow up with your patients to discuss their results with them. Feel free to educate them about how important a hemoglobin A1C under control is. And if patients cancel, reach out and reschedule them as soon as possible. If a patient hasn't had their annual diabetic eye exam and urinary blood work, please reach out and ask them to complete it as soon as possible. Again, point of care testing counts as long as you document the date and the result. And again, educate patients who are at high risk for diabetes of the symptoms of new onset diabetes, such as excessive thirst, excessive urination, as well as weight changes. And finally, if your patients have a hemoglobin A1C of greater than 8 despite treatment, consider referring them to a diabetic educator or to an endocrinologist for further care and therapy. Next slide. So I want to move on from diabetes to talk about the other chronic disease, which is impacted by the chronic care management quality metrics, and that's controlling high blood pressure. As many of you are aware, controlling high blood pressure equates to having a systolic of less than 139 and a diastolic of less than 89. As you've heard me say before, it's that last blood pressure of the year that satisfies the requirement. Your blood pressure can be well controlled from January to November, but if it's 160 over 100 in December, you're not going to get credit for blood pressure control. Here is our quality data for Massachusetts and Ohio and Pennsylvania, where these metrics are measured. In Massachusetts, we were at 80% as of September 30th, and in Ohio and Pennsylvania, we were at 81% control. So we're doing relatively well, and we're hoping by the end of the year, we'll see even further improvement in terms of blood pressure control. On the next slide, I do talk a few minutes about some of the things that are going on with diabetes and hypertension. Many people are now recommending that diabetics with hypertension should have a systolic blood pressure of less than 130 and a diastolic blood pressure of less than 80. Now, the standard, according to the payers, is still less than 140 and less than 90, or 139 over 89 or less. But many people believe that diabetics with hypertension should have lower blood pressure targets. Treatment really should be individualized. And again, one should not necessarily treat to a number, but one should make sure that patients are not symptomatic. Many diabetics have resistant hypertension. And when you see resistant hypertension and diabetes, think about considering secondary causes of hypertension, including primary hyperaldosteronism, renal artery stenosis, diabetic chronic kidney disease, or obstructive sleep apnea. And again, just know that we expect from the payers that the standards for hypertension in diabetes will actually be moving lower in the future. And again, many people believe that an ideal blood pressure is less than 130 over 80 today. However, the standard that you're being measured on is still less than 140 over 90. Next slide. Here I wanted to talk about two specific diagnoses. One includes white coat hypertension, and the second includes MAST hypertension. White coat hypertension is the syndrome where blood pressures are significantly elevated in the office, but when blood pressures are taken at home, they tend to be well controlled at less than 130 over 80. So if you have a blood pressure of less than a 130 over 80 at home, but greater than 160 over 100 in the office, consider obtaining an ambulatory blood pressure monitoring or a home blood pressure monitoring machine. And if the blood pressure is less than 130 over 80, that really equates to a diagnosis of white coat hypertension. But if the blood pressure remains elevated at home, greater than 140 over 90, that patient really merits a diagnosis of hypertension and requires antihypertensive therapy. The second condition is that of MAST hypertension, and that's really the opposite of white coat hypertension. MAST hypertension is when the blood pressure seems to be low in the office, but is actually higher at home and in other settings. Here again, daytime ambulatory blood pressure monitoring or home blood pressure monitoring is very effective. If the blood pressure is elevated at home when it's low in the office, that patient probably has MAST hypertension. And again, lifestyle modification or antihypertensive therapy is warranted. If the blood pressure is not elevated at home and it's not elevated in the office, again, lifestyle modification and annual blood pressure monitoring continues to be the treatment of course with no further medical therapy being needed. And again, if you have questions on this, I'm happy to entertain them at the end. Next slide. A couple of recommendations regarding blood pressure readings. Again, in many offices, medical assistants are taking the blood pressure when patients first come into the office. And again, they're often whisked into the back without having spent a lot of time, and the blood pressure is taken. If the blood pressure is elevated, consider taking that blood pressure again after an initial elevated blood pressure reading is recorded. A physician can often retake the blood pressure when they come into the room, and one should make sure that you use an electronic cuff of the right size. If the patient has a larger arm, you're going to need a larger blood pressure cuff to get an accurate blood pressure reading. If you use a small cuff, you're going to further increase the elevation in the blood pressure that you're detecting. Avoid rounding off of the blood pressure, especially if the blood pressure is 138 over 88. Don't round up to 140 over 90. Actually record and document the blood pressure readings that you get. And please document the blood pressure in structured fields in the electronic health record. If you're adding that blood pressure into the physical exam section, you won't get credit unless it's entered into a structured field as well. A couple of other key thoughts. Number one, please make sure that patients' feet are flat on the floor. When their blood pressure is taken and their legs are dangling, it often can artificially elevate the blood pressure. And again, please make sure that the arm is supported and it's not necessarily drooping down. Again, an arm that's drooped down at the side of the body often can, again, artificially elevate the blood pressure when it's recorded. So these are a couple of recommendations regarding blood pressure reading. And again, whenever an elevated blood pressure is documented, a repeat blood pressure is really absolutely required to determine whether or not that initial reading is real or it was just an elevation that occurred because the patient was hurrying to come into the office and really had not yet relaxed. Next slide. A couple of key messages about blood pressure readings that don't count. A blood pressure reading taken during an acute inpatient stay or an ED visit will not count, and this includes urgent care visits. Patients are often anxious or uncomfortable, having pain, and blood pressures can artificially be elevated at that time. Again, these blood pressures during an inpatient stay or ED visit do not count towards control of blood pressure. In addition, a blood pressure reading taken on the same day as a diagnostic test, where someone has not eaten or had a change in diet or a change in medication, again, that also does not count. So a blood pressure reading taken for an endoscopy or a colonoscopy will not count towards controlling blood pressure. Next slide. I did want to go back and just talk a little bit about kidney health evaluation for patients with diabetes. And again, remember that every diabetic should have a kidney health evaluation annually with an estimated GFR using a BUN and creatinine, as well as a urine to albumin creatinine ratio. Chronic kidney disease occurs in between 20 and 40% of diabetics, and it again is the leading cause of end-stage renal disease requiring dialysis. The presence of chronic disease also markedly increases cardiovascular risk. So at least annually, screening for a urine for microalbumin to creatinine ratio and an estimated GFR should be performed. And if it's elevated or abnormal, patients should be considered for treatment with an ACE inhibitor or an angiotensin receptor blocker. These are effective therapies that decrease the progression to end-stage renal disease and keep patients healthier over a longer period of time. Next slide. So we've talked a lot about management of chronic diseases, and we've highlighted diabetes and hypertension. I want to move on to the second large bucket of quality screenings, and this includes cancer screenings. And on the next slide, you'll see that for cancer screenings, we're talking about breast cancer screening, colorectal cancer screening, and cervical cancer screening. In the future, it's likely that we'll see lung cancer screening added here for those patients that have a history of cigarette or tobacco use. Patients should be considered for low-dose CT scan screening for the future. When you are devising a cancer screening strategy, it's important to make sure that you have 4 essential components. Number 1, you want to make sure that you make recommendations for patients across the board. 2, that you have a screening strategy that you and your team of medical assistants and nurses in your office can all support. Number 3, that you're persistent in reminding patients, and most patients need to be reminded several times before they follow through, especially with colorectal cancer screening. And 4th, that you carefully follow your screening rates to determine whether or not your screening policies are making a significant change in patients' behaviors. Now, on the next slide, let's walk through the cancer screening measures specifically. So the first is breast cancer screening. And the population that the payers are looking to look at are women ages 50 to 74. I do want to stress that many people, and in fact, most providers, are screening women for breast cancer at an earlier age than age 50. So we recommend, again, that you screen women beginning at age 40 for breast cancer, and that you screen them at least through age 75. And again, if women are healthy, you can continue to screen them annually at least through age 80. But the payer measures are breast cancer screening annually with a mammogram for women ages 50 to 74. Secondly, colorectal cancer screening. And here we're talking about all adults ages 46 to 75. You probably will remember that in the past, colorectal cancer screening began at age 50, but we've now moved the ages to age 46, beginning cancer screening at a younger age because of the increase of prevalence of colorectal cancer in our society. And it's much higher in certain subpopulations, including African Americans. Now, colorectal cancer screening needs to be performed, but there are 5 different ways to do it, including colonoscopy, fecal occult blood testing, stool for DNA with Cologuard testing, CT colonography, and flexible sigmoidoscopy. Each different test has a different duration so that if you screen someone with a colonoscopy and they have a negative test, there's 10 years of colorectal cancer screening that's been accomplished. If you use fecal occult blood testing and it's negative, unfortunately, that only gives you 1 year of screening that's been accomplished, and you need to do that every year. Cologuard testing gives you 3 years worth of testing assurance as well. So we, again, recommend that you choose the appropriate form of colorectal cancer screening that your patients will abide with. Many patients are somewhat averse to colonoscopy, and so fecal occult blood testing or stool for Cologuard is certainly effective ways of colorectal cancer screening for those patients that don't want to have an invasive procedure or take a day off from work. And again, please document in the record your recommendations and the results that you obtain. The third form of cancer screening has to do with cervical cancer screening. And here we're screening women ages 24 to 64. And again, we're starting with cervical cytology, and we're adding HPV testing to those patients. And again, we're recommending that women have this at least every 3 years, unless they've had a hysterectomy with no residual cervix. Again, cervical cytology and HPV testing are considered the two large components for cervical cancer screening for women ages 24 to 64. So these are the three large cancer screening recommendations. Breast cancer screening for women ages 50 to 74, colorectal cancer screening for all adults aged 46 to 75, and cervical cancer screening for women ages 24 to 64. And again, any questions, please feel free to enter them into the Q&A chat. Next slide. So the third large bucket for quality screening has to do with immunizations and well care visits. On the next slide, you'll actually see some of the recommendations. So again, we recommend flu vaccinations for all children and adults. And for children below the age of 2, we recommend a series of immunizations, including 4 Tdap vaccines, 3 infant polio vaccines, 1 MMR, 3 Haemophilus influenza B vaccines, 3 hepatitis B vaccines, 1 varicella zoster vaccine, 1 pneumococcal vaccine, 1 hepatitis A vaccine, 2 or 3 rotavirus vaccines, and 2 seasonal flu vaccines by age 2. And again, most children need 6 well visits between ages of newborn to ages 15 months to accomplish all of these vaccinations. In addition to these vaccines, we recommend 3 vaccines for adolescents, another Tdap vaccine, 2 or 3 HPV vaccines, and 1 meningococcal vaccine. I'll come back to the HPV vaccines in just a second. In addition, we recommend beyond immunization well care visits. So for well children, we recommend 6 well child visits by ages 15 months of age, 2 additional well visits between ages 15 months and ages 30 months, and then 1 well visit annually for ages 3 to 21. And for adults over age 21, we recommend an annual well physical examination to evaluate all of the patient's chronic medical illnesses, quality gaps, and risk coding opportunities. In addition to the well care visits and immunizations, we also recommend 3 specific pediatric tools. Number 1, developmental screening in the first 3 years of age to determine whether or not patients have developmental disabilities. Number 2, lead screening in children. And number 3, for those individuals on Mass Health, topical fluoride administration. So these are the well care and immunization recommendations. And again, many of our payers are incentivizing these behaviors with significant quality gaps. Next slide. Here I want to talk about HPV immunizations. The American Academy of Pediatrics recommends that children get 2 doses of the vaccine between ages 9 and 12. We do know that the vaccine is more effective if given sooner. Preteens produce more antibodies after vaccination than older adolescents do. Their immune system is just much more aggressive when it comes to seeing a vaccine. We also know that HPV vaccination will afford some children protection from cancers. We know that HPV, unfortunately, is associated with a large number of different cancers, including oral cancer, pharyngeal cancer, anal cancer, penile cancer, as well as cervical cancer. And when kids are immunized at a younger age, they're afforded protection from cancers that may occur if they're not immunized. So we strongly recommend that children be vaccinated with 2 doses of HPV vaccine between the ages of 9 and 12, giving them additional protection against HPV-related cancers. Next slide. So we've talked about chronic disease management. We've talked about cancer screenings. We've talked about immunizations and well care visits. And I want to just highlight the other measures that are part of our quality measures for 2024. On the next slide, you'll see acute care measures. So here, we're specifically talking about the use of antibiotics. In the past, many patients will show up at their doctor requesting an antibiotic for a cold. And we're strongly recommending that if you are going to prescribe an antibiotic for an upper respiratory infection or bronchitis, that you have appropriate indications. So if you're treating someone with a sore throat, please make sure you do a strep test and document the results of the test before you prescribe an antibiotic. Please don't use antibiotics for upper respiratory infections. They're usually viral in origin, and they're very unlikely to be improved with an antibiotic. And similarly, we avoid recommending antibiotics for treatment of acute bronchitis. Again, it's likely viral in origin. Unfortunately, antibiotics are not going to make the disease better. And all we do with antibiotics is expose people to risks like C. difficile infections and also increase the likelihood of resistant bacteria. So again, our payers are strongly incentivizing the avoidance of antibiotics when appropriate. And again, if you do feel the need to use them, document that in your note. Now on the next slide, I'm going to talk about behavioral health quality measures. So again, as we have in the past, we strongly advocate screening for depression at every opportunity. We also recommend antidepressant medication management and follow up any ED visit or acute hospitalization for mental illness within 7 days. We also recommend that if a patient's been seen for a substance abuse visit in the emergency department, those patients also be seen within 7 days. For those individuals with substance abuse, we recommend a substance use assessment as part of their primary care provider's oversight, and that patients be recommended to engage in alcohol or other drug abuse dependence treatment. You can certainly initiate treatment or refer it to other specialists, but again, it's important that patients hear loud and clear that alcohol or other drug abuse dependence is a medical condition that warrants treatment and can certainly be treated appropriately. Finally, utilization measures. We want to try and avoid potentially avoidable ED visits, as well as unplanned readmissions and ED utilization. Again, we want to make sure that patients know that our practices are open and available for them to be seen. And if they do have a concern, we can see them as an alternative to going back to an emergency room where they'll wait for a long period of time and they may not see a provider that knows them as well as you do. Next slide. I do want to again highlight the need for screening for depression. Please make sure that if you do this, you use a structured field. If you're using Athena or ECW, it's very easy to check and make sure that your depression screen goes into a structured field. If you're not sure whether or not your EHR has a structured field, contact your EMR vendor or our performance liaisons and we can help answer that question. If you're not sure when billing, please make sure you enter the appropriate G code. If it's a positive depression screen, G8431, and if it's a negative depression screen, G8510. Any depression screen requires an evaluation at the end, whether it's positive or negative. And if it's positive, a follow-up plan must be documented. The next slide shows the 2 questions that are part of the PHQ-2. Over the past 2 weeks, have you been bothered by little interest or pleasure in doing things and or feeling down, depressed, or hopeless? Again, one should answer not at all, several days, more than half the days, or nearly every day. And again, you can then make a determination whether or not the depression screen is positive or negative. A screen of greater than 3 points constitutes a positive exam. And again, one needs a follow-up plan, which can be prescribing an antidepressant, referring the patient for counseling, or further care and therapy. Next slide. One last preventive measure I wanted to highlight is the fact that pre and postnatal care is now considered a preventive measure for most payers. Many value-based care entities are emphasizing improved patient outcomes when patients get adequate prenatal and postnatal care. So for every woman who's pregnant, they should have 1 visit for prenatal care within the first trimester and 1 visit for postnatal care between days 7 and 84 postpartum. And again, this can be done by an obstetrics gynecology individual, or it can certainly be done by a primary care provider as well. We want to make sure that patients get care, and it really doesn't matter whether it's you or an OBGYN or someone else. It's just important that the patient get the care that they need. and that the appropriate elements are covered during that visit. Next slide. So I want to stop in terms of talking about quality and move on to patient experience. Whether or not we can agree or not, the payers have all decided that patient experience is a quality metric. And while it may not seem as important as control of blood pressure, in the payer's eyes and in the patient eyes, it is the voice of the patient in terms of whether or not their interaction with you has been a good one or not. On the next slide, you'll note that we are sending out a tip of the month for patient experience, and that the theme for the first 3 months of 2024 is personalized care. So in January, we'll be talking about gathering pertinent patient data, including up-to-date contact information, as well as sexual orientation and gender identity data. In February, we'll be talking about maintaining a safe environment, including making sure the office is clean and that we're using standard precautions interacting with patients. And in March, we'll be talking about patient privacy, using discretion when gathering personal data, staying organized to avoid any HIPAA issues, and making sure that patients feel like their privacy is being protected. Again, for those of you that may not be aware, our patient experience vendor is Press Ganey, and Press Ganey sends out surveys to patients by electronic means, either email or text, almost immediately after the patient leaves our office. On the next slide, you'll see a little bit more information about this. And again, I wanted to start by highlighting those groups that have done a phenomenal job and are over the 90th percentile in terms of patient experience. On the left, you'll see SHCN affiliate groups, and on the right, you'll see SMG provider groups. And you'll see that these groups come from all across the country: Arizona, Massachusetts, Florida, Texas, Ohio, and Pennsylvania. And I want to say congratulations to all of these individuals for doing a great job in terms of patient experience and having so many patients acknowledge that the care that you're providing is not only high quality in terms of the metrics, but it gives them a good feeling that they're valued in terms of the interactions you're having with them. On the next slide, you'll see patient experience data broken down by region. In the upper left-hand corner, you'll see the Northeast region. Below that, you'll see the West. On the right, you'll see Central, and then below that, you'll see the South. And again, you'll see top box scores really have been running slightly improved year over year. In the North, we're at 83% for SHCN and 85% for SMG. In the West, we're at 72% for SHCN affiliates and 83% for SMG. In Central, we're at 83% for SHCN affiliates and 85% for SMG. And in the South, we're at 81 and 86% respectively. So we're in the 80s for the most part. And again, we're getting closer to all of our regions having hopefully top box performance in the 90th percentile. So again, congratulations to everyone for improvement in year over year. Almost everyone has gotten better compared to 2022. And we hope that 2024 will be a year of continued improvement. Now on the next slide, a couple again of reminders. Remember that patient experience surveys only go to patients if they've not already received one in the past 90 days. If they have gotten one in the past 90 days, they will not be getting another. Secondly, survey invitations are sent by text or email. So getting accurate cell phone numbers and email addresses makes sure that patients are more likely to get their survey delivered. And third, please take a minute to talk to your patients about the fact that a survey will be coming. It will only take a few minutes, and it would mean a lot to us if they could provide feedback. One of our practices has traditionally had a very high survey response rate. That's Steward Primary Care Vero Beach. And when we asked them what they were doing, they had two major areas where they were doing something slightly different. Number one, they had signage in the waiting area and in each exam room to inform patients of the survey. And secondly, providers and staff consistently inform patients of the survey and ask for their participation. So thank you to the Vero Beach team for providing that insight, and feel free to adopt this if this seems like it's something that would be suitable for your practices to continue as well. Next slide. So I want to move on and talk a little bit about risk adjustment. And on the next slide, there's a little cartoon and notes that Dr. Katz, you forgot to code for Mr. Smith's below the knee amputation today. He notes, what's the big deal? I did it last year. And unfortunately, his secretary reminds him that you have to code for certain conditions every year to get risk adjustment credit from the insurers. So if you take away one thing from tonight, please note that for risk adjustment, every condition has to be recaptured every year in order to gain credit. Now, risk adjustment is a way of calculating the severity and acuity of a patient's illness. In terms of patient acuity and severity, we are able to calculate a risk adjustment factor. This is a score based on the diagnoses that you have attributed to that patient, and that score is basically added up. 1.00 denotes a patient with average acuity and severity of illness. A risk adjustment factor score of below 1 indicates a group of patients who have, unfortunately or fortunately, a acuity and severity of illness that's healthier than normal or less sick than normal. And a risk adjustment score of greater than 1.0 indicates a group of patients that are sicker than average with a higher acuity of illness and a higher severity of illness than the average population. If you take a look at the total category, which is the fourth column in, for several of our payer contracts, including Massachusetts, the Blue Cross Blue Shield AQC contract, Florida Blue in Florida, Anthem in Ohio, and then the Harvard Pilgrim contracts, you will see that our average risk adjustment factor is below 1. This would indicate to the payers that the average severity of illness for the patients that we're seeing in our practices is healthier than the average patient being seen in the Commonwealth of Massachusetts or Florida or Ohio. And again, it would suggest that our patients are not as sick as other practices in other healthcare systems. Now, we have been getting better year over year, but the market has actually been getting better or having a higher risk adjustment factor score at a rate faster than ours. And so one of the things I wanted to ask you tonight is to please consider, when you see a patient, reviewing the chronic medical conditions that affect that patient so that we can accurately depict the severity and acuity of illness for our patients. Now, on the next slide, I want to talk about some of these opportunities. First and foremost, an annual physical exam is a great opportunity to perform risk adjustment coding. Every time you see a patient for a physical exam, you can review their medical history, identify emerging health risks such as tobacco, alcohol, or drug abuse, and achieve goals aimed at quality reporting and risk adjustment. You should assess the status of all active conditions on the problem list, including the treatment plan, and then list these accurately in the final diagnostic statement, which has the ICD-10 codes and the attributed risk adjustment factor scores. If you can do a physical exam, and remember that for many patients of the commercial population, many of those patients don't schedule a physical exam, there are other opportunities to do risk adjustment factor coding. On the next slide, you'll see a couple of these. First, a sick visit. If you're seeing a patient because they're sick, you can certainly address the acute illness that the patient is being seen, but review the problem list, the past medical history, and the medication list, and address any other conditions that might be present that are chronic in illness. Second, a follow-up visit. If you're seeing a patient in follow-up of their hypertension or their diabetes or a follow-up after a recent hospitalization, again, address the conditions being followed up with a clear treatment plan, review the patient's problem list again, their medical history and their medication list, and again, address any other chronic conditions that were present, but not necessarily the reason for their follow-up exam. And finally, as I suggested on the earlier slide, an annual physical is a great opportunity to address all of the patient's chronic and acute medical conditions. One can capture and address all of these, including as part of the assessment and plan, and making sure that patients are aware of the fact that you have an accurate depiction of all of their medical problems. Every visit is an opportunity to accurately risk adjustment code for a patient. And it's an opportunity to address all their chronic conditions to make sure that they've been addressed at least once a year, no matter what type of care they're being seen for. Next slide. I do want to note that if you're seeing a new patient for preventive care, one can use CPT code 99381 to 99387, depending upon the age of the patient. And if you're seeing an established patient for preventive care, one can use 99391 to 99397. If you're doing an annual physical, one can use the ICD-10 code of Z00.00 if there are no abnormal findings, and Z00.01 if there are abnormal findings being noted. Again, existing chronic conditions that are considered stable at the time of the physical should still be assessed and documented on the physical exam. And if you're seeing a patient for a physical and an acute condition comes up, you do need to document that with a separate E&M code and a modifier that includes -25. Next slide. I do want to note that supporting documentation needs to be part of your note when you're addressing any chronic condition. Supporting documentation can include evidence that the condition has been assessed, that the active condition is being treated with their medication or a treatment plan, and or that there are physical exam findings to support that. Those signs and symptoms are important to document in the note. Please make sure that medication lists are accurate and up to date, especially for high-risk medications, and document any relevant diagnostic and lab testing in the progress note, including your interpretation. As the cartoon suggested when we began this session, any condition that includes an amputation or an ostomy should be documented and captured every year. And please limit the use of abbreviations to those that are only universally accepted. Again, the most important concept here is that every condition needs to be recaptured at least once a year. Finally, some medical conditions need 2 separate codes to accurately depict the severity of illness. So combination codes usually will include a primary diagnosis as well as a specified complication. So if you're seeing a diabetic who has peripheral vascular disease, one needs to comment about both the diabetes, E11.9 or E11.5, as well as the specific circulatory complication, such as peripheral vascular disease or a blockage in an artery to the lower extremity. Secondly, if there's a sequela or late effects of a stroke, one needs to again document the stroke with I-69, as well as documentation of the late effect, including paralysis like hemiplegia, dysphagia, difficulty swallowing, aphasia, or other combination consequences of the stroke. Third, if a patient's undergoing cancer care and has a complication from that cancer care, one needs to document not only the acute cancer diagnosis like breast cancer or colorectal cancer, but include the complication, including infection, low platelet count, drug-induced neuropathy. And again, if you're coding a non-pressure ulcer, one needs to code the ulcer as well as the cause, such as angiopathy, diabetes, or venous hypertension. So in these situations, one needs not only the primary code as well as the complication to accurately depict the severity of illness. And again, this is most commonly seen with diabetes. Next slide. I want to move on and talk a little bit now about performance and how the Steward Healthcare Network can help you to satisfy all the things we're asking you to do tonight. So for 2024, we have several performance plans, and these really include comprehensive diabetic care, including a hemoglobin A1C, an adequate blood pressure, an eye exam on an annual basis, kidney function testing, and the use of a statin. We're also having a cancer screening campaign this year for colorectal, breast, and cervical cancer. And we're also having a cardiovascular health campaign, including adequate blood pressure control and use of a statin. We will be providing rosters as well as quality training on a quarterly basis. And we will also be providing to you rosters on a monthly basis so you know which patients have open gaps of care that need to be maintained. And we'll start that next month in February. Please note that we also can come up with a unique roster to meet the need of your practice if you have a specific concern. So if you want to know all the diabetics who haven't had a hemoglobin A1C in the last year, we can get you that information. Next slide. I do want to talk about the fact that for most of our practices, you are connected through your electronic medical health record into Steward Healthcare Network's electronic data warehouse. And if that is the case, we can give you projected performance data so that your practices know which gaps of care need to be addressed. In addition, many of you have on-site or remote performance liaison access, and our performance liaisons will have the ability to review your scheduling history, to look at patients before you get to see them, and to identify open quality and risk coding gaps. This is specifically important so that you know before you walk into a patient's room what you need to make sure gets accomplished during that visit, including blood pressure control, diabetes control, cancer screening, immunizations, or other things that we've touched on tonight. Next slide. Finally, I want to just highlight for you practice workflow reminders. Again, for those of you that have electronic health records like Athena or ECW, we are often leaving we're often leaving notes for you regarding quality performance alerts with a sticky note or a yellow sticky. Again, we may be asking you to order a hemoglobin A1C or a mammogram or a colonoscopy. When you're seeing the patients face to face, we may ask you to recheck an elevated blood pressure reading. And again, it's very important that when you go into the record and you see an elevated blood pressure, that you consider doing that before that patient leaves. And again, we're specifically asking for you to complete depression screening on every patient at every visit. And finally, for continuity of care, we want to make sure that patients get referred to specialists. And when they do, you get a consult note back so that it incorporates as part of your record. And that when you order testing, you get the results of that, whether that be colonoscopy, mammograms, et cetera. So some of these workflow reminders will be incorporated as part of your practice workflow moving forward. Next slide. So I wanted to say thank you for spending an hour with us tonight. I know that many of you have taken time away from your family and have had dinner with us as opposed to with them. We do want to acknowledge how important we think this is and say thank you to you for taking time to be with us this evening. Please look for an email with information on how to claim CME, and please look for an evaluation that we think are extremely important in terms of telling us what we do well and what we can do better moving forward. So thank you so much, and I'll now ask if there are any questions. Again, if you want to ask a question, log on to the Q&A icon, enter it in, and we'll be reading them out now so that we can answer them before you jump off. Are there any questions for us?
There was one question that I was able to message separately and answer.
Okay.
So nothing right now.
Okay. Well, with that, if you do have questions, please don't hesitate to email me at joseph.weinstein@steward.org or to chicken.qualityteam@steward.org. And again, the materials will be being mailed to attendees 24 to 48 hours after the last live training session, which is next week. Thank you again and have a great evening. Good night, everyone.